Good morning, everyone, and welcome to our session this morning on integrated care within Northern Ireland. My name is Martina Moore, and I'm a Director in the Department of Health here in Northern Ireland, and I'm leading the programme of work at the minute to develop and implement a new integrated care system in Northern Ireland. So I'm absolutely delighted that we have this opportunity this morning to take you both through the work that we're doing within the department in developing the ICS model, but also those examples of integrated work that are already at play within our system. So what we're going to do today is run through all 5 of the presentations and then hopefully have the time at the end for your questions. We are going to begin with the 3 presentations really looking at the integrated work that's a practice in primary care at the minute, and then we're going to move across to the integrated care system model that we are developing. So I'm absolutely delighted to introduce our first speaker today, and that's Sinead Hughes from our Southern Health and Social Care Trust, and she's going to talk to you about implementing that primary care multidisciplinary model within the Newry and District GP Federation. So thanks, Siobhan.
So, hi folks, my name is Sinead Hughes and I'm the Multidisciplinary Team Project Manager in the Southern Trust. Just to sort of give you a bit of a background, in 2016, Health and Wellbeing Together 2026, 10-year plan for transforming health and social care in Northern Ireland was launched. As part of that plan, there was a response to the report by Professor Bengoa. There was a key element of the plan was the development of MDT teams. The MDT teams have an increased emphasis on a holistic model of health and well-being, and each team is made up of multidisciplinary team professionals, and that includes our GPs, our first contact physios, mental health practitioners, social workers and social work assistants, the pharmacists, and an enhanced level of our nursing care. So today I'm going to talk about the implementation of the MDT project in the Newry and District Federation. However, my focus for this presentation is not so much on the data and the statistics that you will hear and you have heard throughout the last couple of days, but I'm going to focus on people and their stories. I am delighted, however, to say that the MDT projects across Northern Ireland region, both from our regional team and from our local projects, have been very well represented at the conference. And there are many posters and presentations that have already been delivered. Just to give you an idea where Newry and District is, in case nobody knows where it is, it's in the Southern Federation, and it's one of the 3 operations operating under the governance of the Southern Federation Support Unit. All in all, there's about 72 practices in this region, and it covers a patient population of approximately 426,000 patients. There are 29 practices in the Newry and GP Federation area across a wide geography, and it covers a population of 160 residents, so lots and lots of people. We've had a phased rollout since January 2020, and we have sort of full and partial allocation in 23 of the 29 practices. So we're really keen to get Newry and District Federation complete so we can move forward to our other 2 federation areas. So people, going back to the people, and you'll see in that slide there's photographs, and I'm sorry to say I haven't got photographs of all the people that are involved in the delivering of change within MDT in the Newry and District Federation. Couldn't get photographs of my regional colleagues, so I've just had to sort of name them. But when you look at that slide, you know, there's a plethora of people there. We've got patients, we've got GPs, we've got our GP practice staff, we've got our MDT leads, we've got our regional MDT colleagues, and that includes our IT, our accommodation folk, the people in the data. We've got our community and voluntary sector, and we've got our trust colleagues. So I suppose without these group of people and individuals, I couldn't do my job. And just to say, when I first took up post, one of my key actions was to dedicate quality time to get to know and make friends with every single person in this slide and others. And this has really proved invaluable to me as a project manager. All these people in this slide are the driving force behind the success of the project. They bring their skills, their expertise, and their dedication to the table at all times. Their creativity, adaptability, and problem-solving abilities are essential for overcoming some of the challenges, and we have plenty of challenges, and to achieving our MDT goals. Investing in people development and empowerment has really enhanced our project in Newry and District. And we have learned so much, and it will be so useful in terms of the upscaling and spreading to the other 2 GP Federation areas. So for the next few slides, we'll focus on our staff as that group of people. A well-functioning team of people with diverse talents and perspectives is critical for project success. We have invested time in making relationships with the people that I've previously named. We recently held 2 MDT staff workshops to help and shape our strategic direction of travel. The main aims of these workshops were, first of all, to get everybody together. You all know about COVID. It kind of put a stop to group gatherings, team meetings even. So we wanted to also get to know each other, recognise our collective work, all our achievements and learning, and make connections within and across the MDT teams. We also wanted to get everyone involved in developing our shared sense of purpose, the direction of travel, and the ways of working to embed and grow MDT services over the next few years. We all know that effective communication, collaboration, and mutual support are key elements of strong team dynamics. It is key that we continue to build and trust and foster a positive team culture, which will then enhance motivation and productivity. So in terms of the engagement and the buy-in, you may know that within Northern Ireland and the Health and Social Care family in Northern Ireland, there's a statutory duty to involve and consult with service users and carers in planning and shaping of services. And I suppose in 2018 that was further directed towards a co-productive approach. In terms of the wider involvement of people, and in this case our staff, we know that by engaging our staff as stakeholders in our MDT team project fosters ownership, commitment and support. Understanding our staff and their needs, concerns and expectations is so essential for delivering the outcomes that and also meet their requirements. We're constantly gathering their staff stories. Continuous communication, transparency has built trust and facilitates this effective collaboration on a daily basis. So how do we approach staff involvement and engagement? It's very, very simple. It's not rocket science. We actually listen. We create the right environment to ensure they feel comfortable and confident to share their stories. We ask questions. Where are we now? Where do you want to go to? How are we going to get there? And most importantly, how will we know that we're making a difference? Our people, our staff, are the key in helping us answer all of those questions. So in terms of empowering and motivating staff, I just want to focus on the ongoing work that we're doing with our staff. I feel it's so important that we empower our staff by providing autonomy, resources and opportunities for them to grow. This increases their motivation and ownership of the MDT project. We continue to recognise and celebrate their achievements, and that's really, really important to do. And we've seen that this boosts the morale and it also reinforces that culture of success. Investing in people's well-being and professional development is core to what we do as a project team. We know that it strengthens their resilience and commitment to the project objectives. So you'll see this slide shows just some goodie bags that we give our staff and a wee pot of mint. And we did ask our staff to come back with photographs of what they did with the mint. So we've got lovely herb containers and stuffed legs of lamb. But more importantly, I think we got more photographs of mojitos and cocktails. So it was put to good use. So I'm just going to show you a video. This is a story I want you all to listen to, if you don't mind.
When you see me now, no one would believe how far I've come in the past 18 months. I had lost my life partner before COVID, and with restrictions, it suited me to live a very solitary life, relying on my family to bring me the essentials. I had become a recluse, and that was fine by me. I felt so lost and often went to bed hoping I wouldn't wake up the next day. I just couldn't see a way through, and to be honest, that was okay. I didn't care for living. It was my GP that referred me to their MDT social worker, and it changed my life. She came in at a time when I was lost and gently worked with me, encouraging me with my interest in crafting. With a lot of support, I went to the first Wool Crew class. It wasn't easy. I had no confidence to talk to the other ladies, but in time, I felt at ease with mixing, and through a shared interest, I could feel a change in me. Over a number of months, my social worker helped and guided me to take many baby steps, and in the process, I am living again. I am reconnecting with people and the world. I am enjoying my life and making decisions for myself, and life is better than I ever thought it would be. I really enjoy going to the World Crew. It's very much part of my weekly routine, and I've made many new friends from it. I love how my hobby has supported others in so many different ways, and I get such great fulfillment from that. I am making amazing plans for my future and living my best life, something I never thought I'd do again.
It really is remarkable how far Jane has come in the past 18 months. From the recluse that could barely open the door to me some 18 months ago to now, she has totally blossomed. The change of confidence has been amazing. She is taking such a massive interest in her life, how she dresses, being able to confidently mix with anyone, no longer afraid to make eye contact, ask a question, or work off her own initiative. I have always had an interest in crafting and could appreciate how therapeutic it can be, especially during lockdown. As an MDT social worker, with a role in developing community development opportunities, I was successful in securing funding to start up a virtual craft group, which I called the Wool Crew, which Jane was one of the founding members. As restrictions eased, we were afforded the opportunity to do a meet and greet session, and the patients advised they would like regular classes, with everyone working in their own area of interest, with the goal of crafting for local and worldwide charities that would benefit from our skills. The art of giving is also so important as part of our overall health and well-being. The response has been amazing, not just for the charities that benefit, but also for the patients who have found the group to be a safe haven, forging new friendships and a new purpose in life. It has been very fulfilling for me to see how this group has transformed lives, with one patient stating, "This group is like a blanket that I didn't know I needed." Everyone that attends has their own story of loss, social isolation, and loneliness, but this group has been a gentle way of nurturing support and compassion.
Yeah, so that was just a story I wanted to share, and I suppose my colleague before in another session talked about the seed fund. As an MDT project, we also have a seed fund, and this project availed of the seed fund. I've met Jane, and I've met loads of Janes throughout the project, so it's great to see that this lady is now working with Women's Aid and working for them, delivering programmes. This is a lady who's never worked before and was quite reclusive, so it just shows you the impact that if we invest in our people and give them time to develop, this is what can happen. I'm just going to leave you with, sorry, I need to go back. There we go, some key takeaways. I suppose really I want to encourage you all to embrace people themselves as the drivers of change and development. It's so important to recognise the people and the stories behind the data, emphasising empathy and understanding in data breakdown and decision making. People are really the most valuable asset in project implementation, driving innovation and collaboration and success. And just to leave you with a slide there from a best-selling author. So how do we actually take the data we collect and put it into context? What techniques and tools can we use to analyse the data and draw out the stories it's telling us? Thank you very much.
Thank you, Sinead. And I'm delighted now to introduce our second speaker, Dr. Siobhan McEntee, who's from the Eastern Federation Support Unit. And Siobhan's going to talk to us this morning about elective care services within primary care.
Good morning, everyone. I am delighted to be able to share with you the story that we had to begin the delivering the general practice elective care service. Although I'm telling the story, I work with an amazing group of people, from our managers, our nurses, our GP staff, and along with our colleagues in SPPG and commissioning who have helped us along the way. So what is GPEX, as we call it? It is a GP elective care services. So it was commissioned to design and deliver a range of pathways to better manage some conditions in primary care. We wanted to improve the patient experience, and we wanted to upskill and improve support our GPs in primary care at the same time. So why did we do it? Why did we bother? GP's busy enough. We had strategic drivers for change, and I think if you ask any GP, the patient is at the heart of everything we do. And at that time, in 2015-16, there were over 200,000 patients on the waiting list in Northern Ireland for their first outpatient appointment for a routine procedure. This was the highest and the longest waiting list in the UK, and indeed in some areas, some specialties, the waits exceeded 5 years. So demand was definitely outstripping capacity. There are recruitment and retention issues right across health and social care, and there are high levels of job vacancies, so there really just wasn't enough staff to meet the demand. So waiting lists, we had a look at what we could do in primary care. When GPs do their training, they do hospital specialty work as well and gain a lot of experience that they can use in primary care. So what we looked at, we focused on the referrals to the gynae or the Women's Health Service in Belfast and looked at it across all of our GP practices. So the GP practice with the lowest referral rate, which was 1.6 per 1,000 patients to gynae, and we compared that with the one with the highest, which was 81.5 per 1,000 patients. So I'm not going to say what is right and what is wrong, because there is massive variability and research into referral data, consultations and interpretations. But what we did realise that the GP practice that had the lowest number of referrals actually had 2 GPs that had a special interest in gynecology. They had done these type of jobs during their training. So they were able to deal with the most basic and manage conditions that were best managed in primary care, and they didn't have to refer on. So we wanted to find innovative solutions, primary care solutions for primary care problems. Our problems were that our patients were on long waiting lists, they were representing at the surgery and often in pain or discomfort, and there was nothing we could really do. But we did know that primary care had the skill mix, the expertise and indeed the infrastructure to deliver. So what did we do? We had a 3-pronged approach. We built capacity. We created a new job called a GP with enhanced skills, and this involved a GP who had extra training to enable them to carry out these, manage these conditions in primary care. We know that the portfolio model, it was mentioned in the plenary yesterday, that the portfolio model of a GP is really a very attractive option to our younger colleagues, and we really need to feed into that, and this gave that opportunity. We designed 5 new pathways, an alternative to secondary care referral, because prior to this, that was the only alternative. So these new pathways allowed us to refer to our friend down the road who maybe had skills that we didn't possess in the practice. We established host practices across GP federations and put in it the infrastructure, the governance, the IT and the HR. We actually mostly used the host practices' existing infrastructure and just tweaked it a little or flexed it to meet our needs. Our second approach was education and training to help upskill our GPs and let them, give them advice on how to refer. I'll go into this a little bit more detail later. And our third approach was demand management. So how were we going to cope with this insatiable demand for care? With our consultant colleagues, we locally agreed guidelines for diagnosis and management of the 10 most common conditions in primary care that necessitate a referral into secondary care. So that meant that GPs could use our guidelines to kind of work down and we'd refer at a later stage. And indeed our colleagues in secondary care would say in dermatology now, they see patients at a much later stage than they would have because GPs have gone down the ladder of care. We offered peer support and peer review where we would encourage GPs, we would mentor and also offer them training for procedures, offer them clinic observation, anything that we could do to enhance their skills. And we developed the Confidence In series. So what are these 5 pathways you keep talking about? I can hear you ask, and here they are. So dermatology is one of the first ones. This was done in a northern pilot many years ago. And as you can see, it's eczema. It is acute inflammatory rashes. The reason we chose this is because these patients often are the longest waiters. Understandably and importantly, our secondary care colleagues must prioritise red flag referrals and suspected cancer. So there was nowhere really for these patients to go. And anybody who has ever had a bad rash or a relative with psoriasis knows the morbidity, the discomfort, and indeed the social and psychological problems that having a rash brings. So this is what we started on. Gynecology, we started with HRT management, menorrhagia, and long-acting reproductive contraception, or long-acting reversible contraception. Pessaries kind of weren't in our plan, but we realised one of the localities had difficulties with this. So what did we do? We upskilled our staff, enabling them to take this work on and help the community. So MSK is really sore joints. We work in contact in collaboration with our first contact physios, and what this is really sore joints. So I always think it's best to tell the story, and this is the story that really kept us going when there were bad times. So I had to call him Paddy. Paddy, the 42-year-old painter and decorator who was self-employed. He had a sore shoulder and was awaiting a joint injection on the long hospital waiting list. And unfortunately, due to pressures, other more serious conditions requiring biologic treatment, he was away down the list. When his GP heard about our services, he referred him in. At this stage, Paddy was out of work, was claiming benefits, and was feeling pretty depressed. So he got his treatment in a timely manner. He had his joint injection, his self-care, and his management afterwards. He was able to return to work and go back to providing for his family. He was off benefits, and his depression had lifted. So it's not only, we always talk about holistic management in primary care, and it really is. It affects every aspect. Our primary care service is just kind of a turbocharged version of our minor surgery service, which we offer in GP practices. If you don't have the skills in GP practice, instead of referring a lump or a symptomatic lump or bump to the general surgery waiting list, you can refer to your colleague down the road. And vasectomy, last but not least, is our fifth child. So vasectomy was really born de novo with a GP elective care because we didn't have a GP service before that. What we did was train GPs in the new non-scalpel technique, which meant they could have vasectomies under local anaesthetic. So education and training, just a little bit about our education and training, because this fueled a lot of our demand management. We established robust accredited training programs in collaboration with our local deanery, NIMDA, for joint injections, LARCs, vasectomies. We worked with the local guidelines, which I've already mentioned, and we created a series of webinars for each of our specialties to give people confidence in, and therein lies the title. So it's confidence in dermatology, confidence in MSK. So each of these webinars was co-created with our secondary care colleagues, who again, we worked on the 10 top referral reasons for secondary care. We also created a website of resources that's easy accessible to all of our primary care colleagues, pharmacy included, nurses and GPs. And you can just see there, that's just a little snapshot of our the dermatology aspect of the website. You can see our guidelines are easy. You can go on and do a skin lesion recognition course. You can access any of the webinars, and all of these help with development. So demand management. The aim, we had an unenviable aim to reduce referrals into primary and secondary care. And everybody knows there's no magic bullet to do this. And indeed, during the pandemic, this actually worsened. So, we all know the theory of demand management, but how did we actually put that into practice? How did we reduce referrals for long-acting reversible contraception going into hospital in the first place? So we established a primary care gynae service in each of the 17 federations across Northern Ireland and used and distributed the local guidelines to all the GPs. It soon became apparent that 80% of our referrals into the service were for long-acting reversible contraception, so we are aware that this was a need, a learning need in primary care. There were not enough practical skills to manage. Demand outstripped capacity, and I think that's a theme that we've heard throughout the conference. Demand outstrips capacity in every sphere of health and social care, and we had longer waiting times than we anticipated or wanted for our patients. So what did we do? We established the accredited training in LARC, and GPs applied for the training. They could apply online, and then they would be allocated a trainer. What we did was we prioritised those GPs that came from the highest referring practices so that they would be able to offer the services to their patients to try and balance out the health inequities in the population. So we soon had a waiting list for training, and oh, that old chestnut comes back up again. Demand for training actually outstripped our capacity again. So what did we do? Undeterred, we decided to increase the capacity of our trainers, so we started training our own trainers so that a higher volume of GPs could receive training, and really this was a democratisation of the educational resource. So GPs, once signed off, could work in our service. They could also provide this service for their own patients in the practice. This also generated income for the practice through receiving a financial payment through our locally enhanced service, and it prevented the need for primary or secondary care referral to secondary care services, or to referral for gynae services. Now, I think this was a win-win. The biggest win was for the patient because they got their care. The next win was for decreased referrals into secondary care, and also it was a win for primary care as well because we were able to upskill our staff. So what have we achieved since we dipped our toe in the water and took the leap, as the conference says? Since November 2018, we have seen over 72,000 patients. You can see the distribution there, where gynae is the big one, which we discovered the need, and dermatology. We have 99 practices that have made a referral, and it is my quest before I retire that I will make that 100%. So watch this space. We have established 59 host practices right across the region, and as you can see, we're in even the rural areas where people traditionally would find it difficult to access treatment. So these are little mini outpatient departments based in GP surgeries, and we have 59 of them right across the piece. We've seen over 65,000 patients. And so what do the patients say? Because really, it's the patients that matter at the end of the day. There's no point in doing it if it's no good. So 99% of our patients perceive the service as good, very good, or excellent. And I think you can just see some of the comments there. They might be hard to read. I particularly like the middle one. From the minute I walked in the door, I felt at ease. The girl in reception was lovely and gave clear instructions on where to go. The doctor and nurse who did my appointment were fantastic, very welcoming, and explained everything in a way I understood. And their kind and caring manner made my anxiety disappear quickly. We'd highly recommend this service to others. Now, what I liked about this is this went straight from the front door of the practice right through to where they were treated. And our practices are our bedrock. They're the ones that do a lot of the work, all the work. We employ 150 GPs and nurses on a sessional basis to provide these services through 4 Federation support units. And over 1,500 people have accessed our training and education, either online or practical. And for this, we've won 2 national awards, of which we're very proud. So, what have we learned? What advice would I give to somebody who wants to take this step into the unknown, take that leap of faith we all talk about? The problem, where do you start? How do you start? People will say, I don't have all my ducks in a row. I actually don't think I ever had my ducks in a row, and I'm convinced most of them were pigeons and we're never going to be ducks. So what do? You start somewhere and start small. Review and refine your model until you're content with it to be able to roll it out to other places. So what we did was create standard operating procedures for all our services that practices could just take, embed, and then they can make local tweaks to serve their local population. Be agile. Be open to criticism, be open to challenge. We were one of the first services to start during the COVID pandemic. We were all GPs, so we were used to doing remote consultations. So we quickly just changed this over into the GPEC service, and we were able to do remote consultations using photos for dermatology and a lot of pre-procedural counselling. You'll be glad to hear that no vasectomies were done remotely at this time. So, but we were able to provide patients with pre-procedural advice so that when restrictions lifted, they went straight for their procedure. Another thing is don't fear governance. Governance is your friend. Good governance is your guiding light and can help you prevent problems before they occur. So barriers, any new service, anything anybody does, there's always going to be barriers and concerns. So what did we do? Well, we tried to make friends. I think Sinead covered that in her talk as well. We tried to make friends. We worked hard with people, like-minded people who wanted the service to improve. and it's building relationships. This takes time and it's difficult to quantify, but it is in this magic space that the magic of transformation occurs. So buy-in, how do you get buy-in from your stakeholders? So we had a lot of stakeholders. We had the department, SPPG, GP practices, individual GPs, federations, and most importantly, our patients. So my tip is communicate, communicate, collaborate. So communicate your vision out to your stakeholders, engage them and help them envisage what you see. Collaborate with them, what do they need for their community, and communicate what you're going to be able to do. So what have we learned? We did have our critics, of course, and I welcome criticism because I think that challenges it, and indeed it kept me on my toes. So what did we do? I think the best thing that I could advise is data. Gather your data, gather your evidence so that you're able to allay concerns and dispel fears. I'll give you one example, and this was a real example. We had a number of colleagues who, particularly in rural areas, who were really worried that these services would destabilise the GP workforce, that the GPs would all want to go to something nice and shiny because work's pretty tough at the minute. But what we had already put sort of some restrictions in place to prevent this happening, and what we did was everybody that worked in the GPEC service had to be a GP, and I always said there's a big GP at the front of your title, so you have to be a practicing GP and you have to be in the performers list. And the GPs were only allowed to do 2 sessions in their chosen specialty, so that still left the bulk of their week available for core GMS time. So what did we do? We took a staff survey, and this was actually interesting. 97% of our GPs responded that the GP's role would encourage them to continue working in primary care. And indeed, we saw quite a number of GPs move from doing locum or sessional GPs to become salaried and more substantive posts such as partnerships. We've quite a few now. GPs have taken the leap again to become a partner. 62% responded that working in elective care made them enjoy their core GP work more, and this was just as the variability. It gave you variability in your work, it helped with your career development, it gave you something different to do, and also an expertise that you could bring back to your practice and offer it to them. And 100% agreed that elective care makes general practice in Northern Ireland a career more attractive to younger doctors, which is really important at this current time. As we heard in the plenary, Jennifer Walsh had said about developing portfolio careers in the northern area, and we know from our work about 80 to 90% of the younger GPs would like to do a portfolio role. So where are we now? We're at the stage where we would love to expand. We want to continue improving the patient experience and strengthening primary care. We have non-recurrent funding for 4 of our services, but I'm delighted to say that Minister Swan recently made an announcement to give us recurrent funding for the vasectomy service. From now on, vasectomies, where possible, will be carried out in primary care under local anaesthetic. There will be a few patients who cannot have this procedure, and they will go to hospital. I would like to thank Minister Swan for taking this leap of faith with us. And just to see how far we've come, so we started training GPs and our nurses. Now we've been asked to train urologists in vasectomies, actually bringing it full circle, because they need to be able to do this procedure as urologists, but they don't do them in hospital. So that's where they'll be coming now. So thank you for listening.
So thank you, Siobhan. So we're going to come to our 3rd presentation on our multidisciplinary teams in general practice. So I'm delighted to invite Janice Gulligan from the South Eastern Trust up to give her presentation.
Thanks very much, Martina. So my name is Janice Colligan, and I'm Assistant Director for Primary and Integrated Care in the South Eastern Health and Social Care Trust. My presentation today is primary care multidisciplinary teams, and I'm going to focus on realising the potential. So we know that primary care is the bedrock of our health and social care system, and around 95% of care across the lifespan happens in primary care. But there's only 5.4% of the actual budget sits within primary care. And there was a piece of research undertaken by Dr. Claire Fuller. She undertook this in East Surrey, but I think it is transferable. And she looked at a population of 250,000. And she identified that 60% had a moderate to high risk of hospital admission. She then looked in detail at the top 1%. That equates to about 600 people. And she noted their contacts in the last year. And she found that they had 1,800 ED attendances, 450 outpatient appointments, 400 inpatient appointments, and an astonishing 54,000 GP contacts. So that equates to about 2 appointments per patient per week. And she also found then, by changing the model to a more proactive approach with multidisciplinary teams supporting GPs, support from the community and voluntary sector, and improved working with secondary care, that she was able, and her team were able to reduce hospital admissions and ED attendances by 12%, and GP contacts by 20 to 30%. So that's 216 people didn't have to attend ED, and over 13,000 reduction in GP attendances. And remember, that data is only for 1% of the high-risk population. So it's evident then of the need to change the model and to work in a more integrated way. We know that great things can happen if you have the right care, in the right place, at the right time. But any change requires that leap of faith and a cultural shift and new ways of working, with changes to referral pathways in primary care, to the community and voluntary sector, and to secondary care, and staff co-located in primary care. So in 2018, the Department of Health in Northern Ireland took that leap of faith, and they introduced a multidisciplinary team programme, introducing 3 new roles into general practice. So they were first contact physiotherapy, senior mental health practitioners, senior social workers, supported by social work assistants, and additional investment in health visiting and district nursing. And this model had 3 main aims. The first aim was to better meet existing demand in primary care by improving access to services and embedding that new MDT roles into practice teams. So what have we achieved? Well, our current position in the South Eastern Trust is that we have now 29 GP practices with an element of multidisciplinary teams in them. They're covering a population of over 187,000. We're very lucky to have full rollout within 13 practices in the Down area. Unfortunately, we still have one area of our trust of 12 GP practices with no multidisciplinary teams. But you can see there in the first 3 quarters of this financial year, our multidisciplinary team staff had over 55,000 contacts. 71% of patients had no onward referral, and we supported 92 community and voluntary sector initiatives. The second key aim then of multidisciplinary team implementation is to boost the capability and capacity for early intervention, prevention, and to focus on well-being, really resulting in improved patient experience. Again, you can see our data there. So within the first 3 quarters, our first contact physios have had 25,000 consultations. They treat things like knee pain, shoulder pain, cervical neck pain, with key interventions like exercise and prescription, pain symptom management. We've talked about joint injections as well. Then our social workers, again, almost 15,000 consultations, again, with key interventions like advice and guidance, group work, and therapeutic and emotional support. And our mental health practitioners, in excess of 15,000 consultations, again, focusing on things like CPD, focus interventions, medication reviews, psychoeducation. And then I wanted to include this example for you because I think it really demonstrates the benefits of early intervention by an appropriate practitioner. So this is an example of 2 patients, both with whiplash injuries, but with very different journeys. One was a patient in an MDT practice, one in a non-MDT practice. So the patient in the MDT practice saw the first contact physio on 2 occasions. They had short-term pain relief. They didn't need an x-ray. They had exercise and advice and, as I say, pain relief. And within 3 months, their symptoms had more or less resolved. They'd returned to full activity. In contrast, the patient in the non-MDT practice was seen by their GP on 3 occasions, referred for an MSK assessment. They then were referred to core physiotherapy and had to wait 6 months because of the waiting list and had 6 appointments. They're currently on a raft of medication there, opioid and analgesia, antidepressants, diazepam, required an x-ray, are waiting for an MRI. 6 months on, they're now out of work. Their home situation strained. They have pain, continuous pain. And then just moving on, the further aim of our multidisciplinary team implementation was to provide a platform for service reform, supporting that shift of care into primary and community settings, and really resulting in improved collaborative working, improved patient and client experience, and improved staff experience. And you can see there, our first contact physios are managing nearly 77% entirely within their own service, with only 8.4% referral to secondary care. Our social workers, again, 70% nearly, and they work closely with our community and voluntary sector, so they refer on, probably signpost on about 17%. And our mental health practitioners, very similar, about 64%, but only referring 6% to secondary care. But this is not just a focus on illness, but on physical, emotional, and social well-being. And it's really a population health approach. So there's a great opportunity to work closer with our community and voluntary sector. And our multidisciplinary teams are not about duplicating what our community and voluntary sector already do really well, but to work smarter and better together. So in 2022-23, we had over 2,000 patients who were able to avail of MDT community development initiatives and benefiting from the seed funding that we were able to provide. And you can see some of those groups there in the slides, but they're addressing things like isolation and loneliness, dementia, bereavement, frailty, diabetes, asylum seekers, poverty, just to mention a few. And now within Northern Ireland, I think we're at the stage where we have the data there, and we've talked about data, but we have multiple data sources and feedback, both regionally and locally, which are enabling us to really evidence the story of our multidisciplinary teams. And Sinead mentioned there about a patient story, and we have asked for feedback from our service users. This is a thematic review of feedback from patients who have accessed the service or from mental health practitioners. And you can see some of those key themes. They talk about improved communication, about being able to avail of information and coping strategies, about compassionate care, about immediate access to services, and about being empowered and taking back control of their lives. And then we asked our multidisciplinary teams what they felt about working in this multidisciplinary integrated way. And they saw improvements in collaborative working, in communication, in being able to provide early intervention, and about better understanding each other's roles. And then, of course, they would say, what would be better? Well, to have multidisciplinary teams in every GP practice in Northern Ireland. And then from a regional perspective, we've asked our GP colleagues what they felt about the introduction of multidisciplinary teams. And they cited things like improved quality of care, improved patient access, improved patient safety, better use of the GP time for more complex patients. And they felt that it really increased their knowledge through that cross-fertilisation of the multidisciplinary team. In Northern Ireland, then, we've had our recent Northern Ireland Audit Office report, and that's on access to general practice in Northern Ireland. Now, this report was last March, and at that stage, we had 318 GP practices in Northern Ireland, but 39 of those were deemed to be at risk. Within Northern Ireland, we have only one fully fledged, fully supported, implemented MDT practice or federation, that's out of 17. But this report set aside one full section onto multidisciplinary teams in primary care. There was 8 recommendations, but the 2 standout ones are the need really to stabilise the workforce within primary care and the need to really reconsider and to continue that rollout of multidisciplinary teams in every GP practice in Northern Ireland. They also talked about GP fragility, and we know about that within Northern Ireland in March 2024. Over the last 2 years, we've had 24 GP contracts that have been handed back, 13 in contracts in 22-23 and 11 in 23-24. And within South Eastern Trust, we have our own lived experience of that, when last year we had one very large practice of 14,000 patients was handed back, and it had actually 2 sites. And we were given, as a trust, 1 week's notice just to take over management of that practice. I do remember that first day, starting in the practice with 1 GP covering 2 large areas. But we had a major weapon within our trust armoury, and that was that we could actually provide support through a multidisciplinary team to support that practice at the very beginning. So we put in social workers and first contact physios, and it really helped to stabilise the practice, to attract locum doctors and salary doctors to come and work there. And we're quite lucky because within 6 months we have a new provider for the service, but they've seen the benefit of multidisciplinary teams and have kept those on. So then, to summarise then, we know that the introduction of multidisciplinary teams in primary care can really make a difference. We can evidence the benefits from a patient perspective, and it's about improved patient outcomes, about timely access, improved patient experience, providing the right care at the right time, at the right place. And then from a transformation perspective, it's about stabilising GP services, about improved provider experience, services closer to home, and we can evidence value for money. I think within South Eastern Trust, we're really fortunate to have the only fully implemented multidisciplinary teams within our Down area, but we're really keen to progress that rollout so it covers all our GP practices within the Trust area, but all our GP practices also within Northern Ireland. We know that the department is fully committed to extending the model across Northern Ireland as quickly as possible, but it is dependent on the availability of appropriate funding and suitably qualified and experienced staff. And then just to finish, by prioritising person-centred care with collaboration among healthcare professionals, multidisciplinary teams are at the forefront of transforming primary care for the better. And by harnessing the expertise of healthcare professionals, we can really enhance accessibility and improve outcomes for our patients. In conclusion then, the introduction of MDT teams, I think, represent a pivotal step forward to a more integrated approach. Thus, it's evident that the multidisciplinary teams are the forerunner for integrated care services, and there's transferable learning and collaborative approach is key to their future. Thank you.
Thank you, Janice. Just before we move on to the next presentation, can I just remind you all, if you have any questions, to submit them in the app, and hopefully by the end of the session we'll get 5 or 10 minutes to go through those. So I'm delighted then to introduce our next presenter, Vincent Ramirez from the ICS programme team, and he's going to take you through our integrated care system model in Northern Ireland.
Good afternoon, and thanks very much for attending this session on ICSNI, and indeed for your attendance and participation to this conference, which I think brought to Belfast to really coincide with the launch of our new integrated care system here in Northern Ireland. We are now on the third and final day of this conference, and I think it's fair to say that we've seen a huge amounts of quality papers and presentation, heard some really interesting discussions, insight from colleagues from all over the world and at very different stages into their journey to integration. You will have seen examples of how a local approach to understanding needs and planning services is essential to really achieve improved outcomes. And we've just heard about local initiatives with some very successful results indeed, but we need to do this consistently and in partnership with all those who can make a difference. You will hopefully Also, I've heard from Sean Gallagher and Professor Bengoa on Monday morning, who reminded us of the strategic drivers that have been the foundation to developing ICSNI. It's fair to say that we're still very much at the beginning of our journey here, and ICSNI is currently being implemented, and we're working to setting up a new model in shadow form between now and the end of the year. We will now briefly highlight our journey as well as what our vision is for ICSNI before we hear a bit more detail about the role of service users and carers have played in the development of ICSNI so far. But coming back to the roots of this journey, a journey of deep transformation indeed, which has faced many challenges since its inception, but which started with Sir Ian Donaldson's review of commissioning and then Professor Bengo's System No Structures report, which led the department to respond through delivering together the long-term strategic vision for Northern Ireland. And with this strategic context set, and despite the suspension of the Northern Ireland Assembly in 2017, the decision was made to take a phased approach and initiate the closure of the Health Social Care Board at the start of 2018. As you can imagine, this is something that would take time and effort, but enough progress was made to enable us to start looking into the opportunity of developing a new model, a new planning model towards the end of November 19. And with the executive returning in January 2020, things were all set to align perfectly. However, obviously, the work had to be put on hold in March of that year to enable the system to address the many challenges arising from COVID-19. Fortunately, we were able to resume our work toward the end of 2020, and were granted the approval for a work program to develop a future planning model based on an integrated care system approach. This was the start of a vast collaboration and extensive engagement with a wide range of stakeholders, internal and external, including professionals and clinicians, of course, but also critically our communities, our people through our VCS partners, who in Northern Ireland have long played an essential role and demonstrated how invaluable they are, and their action is both regionally and locally. And some of you will perhaps have had the opportunity to take part in some of the site visits that were organized across Belfast the last couple of days. And of course, our service users and carers, as I've already mentioned, and we'll hear in a minute from my colleague Teresa McGarvey, who coordinated our service user and carer workstream. And we was joined by Laura Collins, who will provide some insight into their work as part of the development of ICSNI. But what we've done, we've applied the very principles of what we wanted to develop into our own ways of working, co-production, involvement, and indeed wider engagement. And we finalized a first draft of a framework for ICSNI that was consulted on in the summer of 2021. And in the meantime, the Health Social Care Board was effectively closed on 31st of March 22 and migrated to the new Strategic Planning and Performance Group, SPPG, and we then developed our model further in that context, getting ministerial approval for our approach before the Assembly and Executive unfortunately folded again. But we nonetheless were able to establish a test site in the southern area, which ran from May to December last year. And we have since been implementing the many recommendations that were derived from the learning of this test, adjusting a model and framework accordingly. So there's still a lot of work to do, but we have now started implementing ICSNI, including selection and nomination process for members to our area integrated partnership boards, which I will touch upon shortly. And we are on course to have ICSNI stood up in shadow form by the end of the year, hopefully. But before we go into more detail about the model itself, I thought it'd be useful to play our little video that will illustrate the vision behind ICSNI.
ICSNI provides the framework through which we will plan and manage health and social care services in the future. In a world where we see our population growing and ageing, where we face increasing financial challenge, where our people are waiting far too long for treatment and assessment, ICSNI provides the opportunity to think and act differently. Differently in how we plan, differently in how we manage, how we work, both within health and social care, but crucially, how we work with others. ICSNI is a mindset. It is a way of working that not only focuses on the immediate, but also looks to the longer term, that aims to keep our population well in the first place. It is that need to balance both. To do so, we must maximise the potential of what we already have. And what we do have, our communities who are informed, engaged and understand local need, dedicated individuals, professionals and organisations who work directly with their local populations to deliver for them, a wider public sector and a diverse and engaged third sector working across Northern Ireland to tackle the broader issues which impact on our health and well-being. We have a wealth of information and data. We have a health and social care system that is already integrated in legislation and structurally. What we need is a way of bringing this all together, and ICSNI aims to do just that. It is about connecting people and organisations who are working towards the same vision of a healthier, happier population. It's about enabling them to come together around the needs of that population, to learn from each other, to identify the collective assets and resources that are available, and think critically about how they are being used, to understand what we do well, what we don't, and where we can make a difference. It's about coming together in the most effective way. It's about taking action, doing the work with each other, not in silos. It's about culture. We work better when we trust in ourselves and our partners, when we can share openly, let ideas flow, and embrace the chance to do things differently, do things better. Resources are stretched, and the pressures we face are real. But consider the skills, expertise, knowledge, experience, and resources that each individual part of our system and our partners already have. Now think about what we can achieve if, instead of working in isolation, we bring all of that together. If we can truly harness that potential to ensure that we build a society where we can all live long, healthy, active lives. ICSNI is a way of working that aims to deliver on that.
So ICSNI provides us with a new framework for planning and managing health and social care services in Northern Ireland, focused on collaboration, integration outcomes and person-centred care. Our overarching vision is that of one system working in an integrated and coordinated way to plan and deliver health and care services to improve health and well-being of our population and address demand by placing a focus on people, keeping them well in the first instance, providing them with timely coordinated care when they're not, and supporting people to self-care when appropriate, but also ensuring that we are maximizing the resource that we have available to deliver the best outcomes for our population, optimizing the effectiveness and efficiency of what we do and reducing duplication. But that's the concept, and what will it look like in practice? Well, how will we implement this vision and our expectation that the whole system will seek to work more collaboratively in more integrated ways? Well, our expectation is very much that all parts of the system will go through the same motions to ensure that they fully understand the needs of the population through not only the data statistics and profiles that we have access to, or the input from professional and clinical experts, but also the bigger picture around existing services that are already in place, the related financial performance information of the services, how much do they cost, how much do they deliver for the resource that is being invested, the insight and local intelligence from the community and local population themselves, and involvement obviously will have a critical part to play in that respect, and the identifications of where the gaps are, where the good practice is, where the potential for perhaps expanding those actions that deliver the best outcomes locally is, and streamlining, maximizing existing services to make them more effective and efficient. And importantly, building from the existing assets that are out there and that already deliver for population. And to do that, ICSNI will build on the work of three main components of the system. First and foremost, the Public Health Agency, PHA and SPPG. This is perhaps one of the main specificities of our model here in Northern Ireland, that SPPG, supported by the PHA, will plan and manage integrated care and services across the system, informed by local and regional collaboration. It's very much about integration at every level in how the services and the different pathways are designed, and they will hold the strategic oversight for the planning and delivery of health and social care services. And multi-professional planning teams will, as I've explained in previous slides, seek to understand the need, understand the service provision, as I said there, connect the system, carry the gap analysis, and agree how best to deliver consistent services. There will also be key strategic partners to the other two components, providing guidance, professional expertise, and leadership, but also an ethical and operational support. And they will be commissioning all the regional and specialist services. Pardon me. The PHA as well will provide population health needs assessment to get all the different work starting. We'll then have the Regional ICS Partnership Forum, which will be the single regional forum for the system, a collaborative partnership that will work regionally to support the work of the IPBs, identify opportunities for regional collaboration, support shared learning, and ensure alignment with the strategic direction as well as between the local and regional levels. And working locally in partnership beyond the health social care sector, 5 area integrated partnership boards, AIPBs, will seek to identify local needs, agree priorities, and identify what cross-sector collective action should be taken to effect change with a focus on prevention, early intervention, and community health and well-being. But beyond the operational aspects, it's important to reiterate that ICSNI is a vision. It's a mindset that would provide the opportunity to think and act differently in a well-known context where population is growing and aging, demand is outstripping capacity. It will be all about connecting people, communities, and organizations who are each, after all, working towards the same vision of a healthier, happier population and delivering improved health and social well-being outcomes and reducing health inequalities. And of course, the role of our service users and carers is essential in achieving this. And I will now pass over to my colleague Teresa, who will showcase the work from some of those service users and carers, like Laura, who have usually contributed to developing ICSNI. Thank you very much.
Vincent just stole my thunder. I'd just like to then introduce Teresa McGarvey from the programme, who's going to take us through the work that we have done with the service user and carers in designing the ICS. And Laura, is Laura going to come up as well? Yes, and Laura Collins, one of our service users who's worked with us throughout the programme, will actually then give us her reflections once Teresa's given her presentation.
Thanks, Martina. As Martina said, my name is Teresa McGarvey. I work in the Department of Health and I co-chair the ICS Service User and Care Workstream along with my good colleague Laura Collins and Brian O'Hagan. So first up, our presentation today is about transforming service in partnership with service user and carers to co-develop the ICS model. And I want to owe thanks as well to Claire Forsyth, who's in the audience. Claire was part of this submission. So I'm not going to go into the detail of this slide, but I just want to show the reflection of the inclusive governance structure that we have. And as I say, there's various project teams there, but first and foremost there we have our service user and care work stream, and it was very much part of the overall governance. You can see the Health Minister sets up our group and our steering board is chaired by the Permanent Secretary. So what we wanted to ensure was that the lived experience was embedded in the design of the ICS model, and it was a dedicated strand. And of course you'll be aware within Northern Ireland we have a statutory duty to involve service users and carers, so that's with the reflection we worked on. So just moving on, we wanted to create the conditions obviously for the cultural change. So it's about bringing together the experts, and what better experts than our experts of experience, our service users and carers. We also had colleagues from the health and social care organisations, the PPI involvement leads from the trusts, and of course we had our decision makers within the Department of Health, all coming together on this work stream. And I suppose we were really leading by example. The co-chairs, as I said, was Brian O'Hagan and Laura, my colleague here, and I chaired it as well from the Department of Health. But I think one of the successes of our work stream was the fact that we had pre and post work stream meetings, and those were very beneficial in that we had our service users and carers with us from the outset and keeping them at the start. So our meetings were very productive, we were planning ahead, the meetings were really action focused, and the follow-up. So we had a real good trajectory in place. We met over 2.5 years and we had over 21 meetings. But I suppose what we were reflecting was investing in developing equal trust and relationships whilst designing the model for involvement. So I'll quickly go through this. So all in all with our work there was horizontal and vertical influence, and indeed as Professor bingo I'd mentioned, there was the sideways influence as well. So the co-designers, we had creative thinking together to find the solutions and a range of perspectives to better focus. We had the core infrastructure and our work stream. It wasn't an advisory group as such, it was really part of the design because our service use and cares really did influence it and seen it from their lens to embed meaningful involvement. And it was design and inclusion at every stage. Influence in other projects. We also had our service use and care colleagues sitting on the communications group as well, and it was all about a commitment to deliver on the whole design and implementation. So how did we influence? As a group and in our work streams, we set out to see how we could really influence. So our service users and carers were at the foremost of it all. We would have got webinars. We had the King's Fund from England who come over and we had a very dedicated webinar, and there's loads of webinars on our website. And they really talked about embedding co-production within ICS. Our workstream projects, as I say, we worked very closely with comms and our team, and we wanted to have accessible information that was, public messaging with newsletters, with videos, and I'd encourage you to visit our website because there's good frequently asked questions and videos there. But it was all about getting that message out there and inviting service users to be part of it. Our service users and carers also influenced the whole strategic outcomes framework and a co-production with the finalisation of those. And our service users and carers were involved in a screening tool which embeds involvement at a strategic level. So Vincent referred to earlier about our model, and we have the area integrated partnership boards. So you can see there our service users and carers play a vital role there. They're in there with the chief executive, the trust directors, voluntary community sector, council, GPs and pharmacists. So they have a key role in this planning of our new integrated care system. So we had to embed we were embedding the lived experience. So service users and carers were in the regional group, and we had a couple of our users there to establish the government's arrangements. But we also set up a test which Vincent referred to, and our service users and carers would have designed their role descriptions. And within the test, obviously we set up it in May last year, and it was service user and care involvement. With a few wee hiccups there, we were trying to get the message out. We went out for recruitment, but with no appointees. So I knew my task as co-chair was to really encourage the coming forward and stimulate interest for people to come forward. So we felt that we had a message to get out there about service users and carers because we really wanted their voice at the table. So we had to choose them for the test, but I knew with the task, with the full rollout, we had a lot of work to do. So I suppose we were involved in the learning from the service user and care perspective in the test. So our plans was having a dedicated planning and promotion of the members' appointments. We really worked hard on that to see how we could stimulate interest. I went out and met with involvement advisors from within the trust, met with groups. We co-designed the job description and the information pack with our service users and carers, and we had an online information session, and it turned out to be really successful. We had over 80 people online just to get that message out there to encourage service users to come forward. Our service users and carers were involved in the induction pack, and we're also working with Patient Client Council to develop capacity building training. Another pointer from their group was we have established an involvement advisor liaison group, and it's peer network support for our service users and carers for knowledge sharing and to build that capacity. So just a reflection of the great work that our comms folks did with us when we were promoting the opportunities, and we had a lot of comms coverage. So we had 32 hits on Facebook for people who were interested in their positions, and we also had 10,000 over X or Twitter. So what did we achieve? I think key to it all was the building of relationships, trust and respect. I think we had that from the beginning, and that was reflective of our success. We had structures for partnership that were successfully to appoint this involvement advisors, and we've sourced various training to capacity build them to have them in their position. So the result of all our campaigns, we recruited 37 applications for 10 posts. So we have a good selection of people, and we're delighted we have those in place to move forward with the implementation. So just very quickly, I'm not going to go into the detail of those, but that's we carried out an evaluation of our work stream, and that's some of the comments. You can pick them up later. So on finalisation, I want to go in the reflections, and I think all in all, we always kept our service users and carers at the heart and involved them from the start, and I think that can only be said by Laura Collins. If you want to come and reflect, give your reflections.
Thank you, Teresa, so much. Last week, Oxfam GB published a new paper. It was called Valued, Breaking the Link Between Care, Poverty and Inequalities. Their ask was for a shift to a caring economy where all care is valued as a vital social good, where unpaid care is reduced and redistributed, and where all carers have powerful voices in decision-making. And it is to that very last point that I want to talk today. As a shielding and long-term family carer, I've been following the conference learning over the past few days through the online stream sessions. And today I want to draw upon 3 key themes made in the welcome session on Monday, and they relate clearly to the involvement work stream, its process and its success. 1, vision clarity, 2, teamwork, and 3, people. Number 1, Professor Bengoa in the opening session spoke to the importance of shared language, and he said, make sure the public are part of the conversation. And this is the exact rationale behind our work stream. As very experienced service users and unpaid carers, we are well aware of the information barriers faced by citizens in understanding and navigating the current disjoint and complicated systems. For us, it was imperative to succinctly relay the new culture, the new focus on population health, and why the addressing of the wider determinants of health should not be delayed any further. We therefore allied with the communications workstream to translate system speak, regulatory requirements, and the integration reform agenda into accessible online materials and information sessions. Clear public messaging and active outreach did mean that we were not only able to promote the expected benefits of ICSNI, but also explain why giving of your own time as citizens to the area boards could help shift the outcomes dial. Number 2, Minister Swan in his welcome speech spoke about the importance of building trust and strengthening relationships. And these are the core building blocks of integrated care. Ruth Bader Ginsburg, the American Supreme Court judge, once said these words, fight for the things you care about, but do it in a way that will lead others to join you. And I believe that we as lay workstream members have done just that. We have taken prefigurative action in developing a workstream for change, one to future-proof inclusion of the missing voices in service creation and evolution. We have intentionally designed in lived experience voices, from strategic ideation and influence through to full inclusion, the 10 new involvement advisors across the 5 area boards. We have worked together with staff as equals, listening and learning from each other, leaning in when needed. We have nurtured a form of radical kinship where there's no them and us. We have come together for the greater good. Number 3, Professor Carroll spoke to solidarity and the fact that it is the people who make the change. So what do people on the ground want from an integrated care service? They want to be heard. They want their rights honoured. They want to experience a supportive wellbeing journey. And they want to be recognised as solution bringers. So in planning meaningful future services, we need to move forward from patient-centred care to people-driven care. We've shown in our workstream how positive involvement partnering is possible. We have created a transferable, enabling infrastructure design for strategic co-commissioning, bringing top-down, bottom-up, and middle-out into one model to deliver better social justice for all. Today's problems are from yesterday's quick fix solutions. We need new thinking to address the growing implementation gap. Deeper co-design can only be achieved if we proactively bring together cultural knowledge, research evidence, practice wisdom, and last but not least, lived experience. Our new ICS planning framework with mandated roles and perspectives will help us to see the patterns of change sooner, where we can adapt quickly for long-term system sustainability. And that's the very health equity future that we all want. Thank you.
Thank you, Laura. Can I just say then, as a programme director, that I just want to place on record my thanks to the Service User and Care Workstream, who've been instrumental, I think, in shaping the programme and really helping us to make the progress we have to date. So, and thank you to all of our speakers here this morning. So we do have time for some questions. So again, just a reminder, if there's any more you want to put into the chat, please do. One of the questions we do have this morning is about our area integrated partnership boards, which were part of the integrated care system model that Vincent described earlier, and about the fact that they don't have specific budgets or decision making over service planning. And how do we convince people then that their time will be useful? I think I'll probably take this one myself. I think one of the things I would say is our work on our integrated care system model here in Northern Ireland has evolved quite a lot over the last couple of years. And I think if you were here on Monday, you would have heard Sharon say where we've landed is not where we started. And I think part of that evolution has been through the engagement we've had right across the various sectors about the learning that we've taken from the likes of the test AIPB, and actually where there would be value in bringing people together in those local areas, so where the people around the table would get that value from being involved and where we could actually really make a difference for our population and really listening to the communities and listening to their needs. And I think that really took us back again to that reflection about where we are as a population in terms of our health and well-being and the challenges we see in terms of our health really within our local communities. So I think where we've landed in terms of where we are now for the area integrated partnership boards, it's very much around that focus on prevention and early intervention. And really that sort of ethos of community health and well-being. So in terms of the area integrated partnership boards, our sort of process, our planning way forward in this is about actually bringing all of those partners around the table, about looking at the collective assets and resources we have, and really, I suppose, going to the video, really thinking about how we're using those assets and resources and how we can use them better to really start to make that shift change in our population health. Really tapping into those populations that we aren't reaching at the minute and seeing what it is we need to do to support them. And that's not always health and social care, but I suppose the important part in all of this will be that alignment back into service planning, because we know from that population health approach, if we do want to affect change in our population's health and well-being, we have to have that continuity right through. So yes, we need that focus on keeping people well in the first place, but that won't always be the case. So when they do need our services, that we are making sure that we're actually planning services to give them integrated care, integrated coordinated care in the right place at the right time. So part of this is the continuity right through the system. So yes, area integrated partnership boards, prevention, early intervention, but around that table will also be our planners who are making sure that we bring that continuity. So I think the value is really much in really thinking about how we can make a difference in the communities and how then we've informed that wider service planning. Are there any more? Sorry. How have we implemented shared learning from other areas?
Well, we have very much looked into what happened out there and how we designed our model to fit the specificities of Northern Ireland, but also to look at the successes out there. And I think I've been instrumental in providing us with that insight, but we've also been speaking with colleagues from across the border, of course, in Scotland, Wales, and many different ICSs in England. We looked into all the different parts of what we needed to build to really carry through that transformation, from how do we set our strategic direction, and the experiences from Canterbury in New Zealand were quite instrumental in trying to shape how we did that in the context of adopting an outcome-based accountability approach and aligning to our program for government, which was still as a draft model at the time, but which had been quite common in the last 15 years in public sector in Northern Ireland. But we also had the opportunity to bring in some relevant expertise on board in our own program governance, and we had a quick look friend from England in Stephen Ames, who came to really provide that critical eye to our development and how we worked in our developments. And we mentioned the test in the southern area, which was also attended by Mike Farr, who had extensive knowledge and experience in that. So it's all about capturing that learning, translating it into the non-island context, and trying to develop a model that is fitted for our specificities, the main one being that in legislation we are already integrated in health social care, but maybe not necessarily in practice. So it was all about how do we break that through and carry through our model with all that learning indeed.
And just to add to that, obviously, given where we are today, I think one of the other key factors in all this has been the support we've had from IFIC through the journey, and obviously the connections we're making through to really look across other countries and other jurisdictions, and even events like this in the last 3 days and what we can learn from others. You know, I think one of the things we reflect on when you do listen to the many presentations are a lot of the challenges are the same. We may be coming at it from different approaches, we may have different constructs, but fundamentally the challenges are similar. So any learning that we can take from other areas is vital to the success of the programme. So I think we'll maybe just get another couple in, and I'll maybe turn to our primary care colleagues. And I suppose go on to what I was just saying about the challenge that we face. So a lot of what we've heard in the last few days, and I think it was probably part of the opening presentation about people being our greatest asset. But I think the other observation I've heard quite a lot in the last few days is obviously if you really want to truly integrate and really sort of reach, we talk about a journey, reach, I was going to say an end point, but perhaps make a further progress in that journey, is it ultimately what we need is a cultural change. So that change of mindset, because what we are actually doing is to asking people to work differently. So one of the things that we just wanted to ask, given your different experiences across that, is how you supported the people then involved in your different teams and initiatives to really make that shift change. So going from perhaps where you would have had that traditional GP setting to actually working with others they may not used to be working to, or actually taking on those additional duties. So I'm not sure of any.
Okay, I suppose when we first were implementing, and I wasn't there at the very start when I came in as the project manager and linking with our MDT leads, we were very conscious that anything new you try to implement, you need to be able to translate that into language and communicate that people will understand. And that goes for everybody, because people are people regardless of what their status is or what their professional background is. So we were very conscious of that within Newry District, and one of the things that my colleague spoke about earlier was doing some kind of training with all staff within the GP practices, and we did. Our MDT leads do a lot of on-the-ground training, but we introduced the health literacy training as well for frontline staff, because the MDT model was quite new to the admin section of the GP practice, and they're your first port of call. They're the first people that people see and hear when they come into the practice. So that was quite successful as well. But it's also gone back to that translating any new policy, any new strategy, or any new change into language and communication that people will understand, because working in the trust in big organisations, you get information and it's quite top heavy sometimes. So it's investing the time to explain that to people, and that goes back to having dedicated time to actually speak and listen to your staff, and sharing that story, sharing that strategic story with people on the ground. I think that's probably. I don't know if I've answered your question.
No, you have. And I'll probably move back to Vincent, actually. One of the things then, I suppose, again, is about how do you measure success, and how you evaluate integrated care. And again, we've heard about all the difficulties, and it's just, I suppose, it's a more specific question about ICSNI and how we intend to measure our progress. And I know Vincent's done a lot of work on the strategic outcomes framework, so I'll let him take this.
Yes, and again, that in itself is very much part of transforming how we perceive things and how we actually understand and perceive what success is. Very much, like I mentioned, the program for government, adopting an outcome-based accountability approach, very much trying to look at what is actually a successful outcome and what is it that people want. And I think we've tried to, and I see many of our colleagues here in the room today have contributed and co-produced some of those outcomes that we're trying to achieve, just to try and expand from our program for government and really looking at what is it that people want when you ask them about what's important about their health and well-being. So it's going out there to our population and then translating that into, first of all, inspiring outcomes, but then how do we translate that into quantifiable measures, and how do we use what we've got in terms of data information, and we do have a wealth of data information, as Martin was saying earlier, but how do we then translate that into bringing the story around the numbers, as was mentioned earlier as well. So it is a challenge, that coupled with bringing the operational side of things as well into how do we measure performance of the system in a new way of thinking, in a new mindset that we'll be trying to instill through ICSNI. But what is a good outcome in terms of how we invest locally, regionally, in all the different services, but how do we then address the need in the first place and then help people get healthier, very much.
Thank you. So I'm conscious we're nearly on 1 o'clock and I'm sure you'll want your lunch. I think if it's okay, Laura, I'd like to maybe end with yourself as having the final word. Obviously, you've been involved in the work stream for quite some time, but I think there was a question here about experience. So integrated care, what would that mean? If we realise true integrated care, what is the difference that would make actually for you as a service user?
Is this on? Yes, it is. It is. It is. For me, is having a service that, as a carer, I don't have to go and find. I've become a super integrator, really, over the years. I've learned to navigate the system. And I shouldn't have to do that. As a family carer, I have enough to do caring. So I would love that the system would actually have services that are available that meet the needs of my son, but also my needs as a family carer. I know as other services are not what they once were, and the funding is really, really tight, that demands will be increasing on family carers and on citizens to start caring for the first time. So I would like for them to be found early in their caring journey, because journey is the word that has pervaded the past 3 days. I would love that they would be found early in their journey and supported to be carers who want to share their love, but they also have great expertise keeping people well at home and out of hospital. So to value what they do, but to be there for them and for that structural burden to go away, and for us to have a quality of life the way we want our loved ones to have one too. Thanks.
Thank you, Laura. Just to suppose on closing, and again, just reflecting on what you said about the journey, and it has been a theme right through the last 3 days, and it is a journey, and I think it's one that we have to constantly seek to really evaluate where we are, assess, and look to continually improve. But I think, even from the presentations today, if we do so, working in co-production with our service user and carers, with our partners, with all of our partners, both within the system and without, then we actually can make those improvements and build that model that actually will make that change. And I think, again, going to our first 3 presentations, reflecting on Northern Ireland, we are starting from a good foundation. We have integrated work at practice right the way through in different various guises, and really then the challenge for us is just to make that at a systemic level. So thank you so much. Thank you to all of our presentations here today, and I hope you enjoy the rest of the conference.